Michigan. Oh, he was great. That was my favorite course in all of Michigan.
And
It was called Behavior,
we've got some birthday parties.
Persuasion and Behavioral Change. It was on,
So we'll see what we get to.
different ways of persuasion. We did brainwashing and advertising and
I do that for here.
I'm not
this year.
You got to get their attention. It's got to be repeated.
Good evening, everybody, and welcome to our meeting. At this time, I'd like to invite you to join the board for the Pledge of Allegiance.
I, the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
May we have roll call?
Summers.
Here.
Dr. Hans.
Here.
Mrs. Raspecki.
Here.
Dr. Arrington. Ms. Newman. Dr. Taub.
Here.
Dr. Klotz.
Here.
Ms. Schulman.
Here.
Mr. Rubin.
Here.
Ms. Kucharik. Mr. Landsman.
Here.
Mr. Furman.
Here.
Thank you.
Oh, yes, it is working. This is our first opportunity for public comment. No one has signed up, but would somebody like to make public comment at this time? Mr. Brooks, welcome.
Does this work? Very good. Good evening.
Into the microphone, though.
Microphone?
Yes.
You think I would be used to that? One, I just wanted to congratulate the board on their selection of CEO. Also, just want to let the board know that I and Detroit Wayne are here to assist in any way that we can and to continue to strengthen our partnership. And other than that, just want to say hi.
Well, I know I'm not supposed to comment, but thank you very much. Would anyone else like to make public comment at this time? I don't see anyone. There will be another opportunity at the end of toward the end of the meeting. May I have a motion to suspend the rules and approve the agenda?
So moved.
Is there a second? Second. It's been moved by Mr. Furman, seconded by Mrs. Eleanor Risbecki, I'm sorry. I was looking at Kucharik. Is there any discussion? All in favor?
Aye.
Opposed? The motion carries. Now may I have a motion to approve the consent agenda, which includes the approval of the board minutes from April 17, the CAC minutes from April 18, and the RRAC minutes from April 5th. Is there a motion?
I'll move.
Second.
Sorry, who made the motion? Okay. It's been moved by Mrs. Summers, seconded by Ms. Schulman. Any discussion? All in favor?
Aye.
Aye.
It
Opposed?
was actually, I seconded it.
Oh, I'm sorry, I
Yes.
thought I heard you. You didn't? I started to. Oh, okay. My apologies, Dr. Klotz. Dr. Klotz seconded the motion, and the motion carries. Our first topic is voters' work group presentation, but apparently there's been a miscommunication, and one of the presenters cannot be here. So we're going to postpone that presentation for another meeting and move on to our March financials. Ms. Eliason. I'm sorry, I took you by surprise.
Have the March financials. So I'll go through and give you a couple of items of note and then take any questions that you might have on each statement as we go through. So if you're looking at the statement of net position, also known as the balance sheet, you can see that this is the month, if you remember in February, we had where the department paid us a little bit late, so you saw the significantly lower cash amount, but that was because the department didn't actually pay us until March for the February payment. So that has been adjusted in March, and you see now there is back to a positive cash balance. And what you'll see as we further move down is this is the month where we recognize the adjustments for the sale of the old building. So as you move down to capital assets, you'll see that the land asset is now gone from the March statements. And you see that the building asset has gone down significantly, and that's because we sold that building and that was transferred into the cash asset. So moving down from there, you can see that we are currently, I'm jumping down to net position. You can see currently, the current year net position is continuing to go increasingly negative. So that's because we have a planned use of reserves this year. So remember, as we talked about last month, because we are doing this transition year, we do have built into the budget a use of reserves. So you're going to continue to see that go up for this fiscal year as we transition to funding models and starting to see some of that come back. We have heard some encouraging information related to the DAB issue, that we are likely to get an adjustment in fiscal year 18, so I don't know how much yet. But we're hopeful that we will see that in 18, and like I talked to you about before, either way, it will start to build back into the rate process in fiscal year 19. So we are expecting to see that adjustment. I have a rate-setting meeting on June 8th, or I believe it's early June. So I expect to have that information for you for the June Committee of the Whole. So what you see below that is the substance use net position. You'll see that one's remained consistent because that money is not, those fund sources are not actually planned to use any reserves. In fact, we will likely be contributing again to PA2 reserves that we have in the last few years. So you'll continue to see that fund balance grow over the next few months and as we continue to collect that and not actually have a budget to spend all of that. Anybody have any questions before?
Mr. Landsman.
Yes. I saw your letter earlier this week as well to the legislature. Thank you. And it was very nice. If we do get a reversal in some of the spend, or I'm sorry, not spend, if we get a reversal and we have an increase in funds from the state, would that then reverse our downward spiral of the ISFs?
So what that will do is, to some degree, however much we get, it will offset the amount of reserves that will be necessary to cover this fiscal year. So the short answer is yes.
We're not looking at actually increasing the spend that we have of funds. Okay.
Not at all. So if you recall from the budget, we have a planned spending of Medicaid well over what our planned budget of revenue is. So if we get some money from the department from a Medicaid perspective, it will just offset the amount that's necessary. But remember, too, we're in this transition year with service models. So we're starting to get our data together as far as where people are at and meeting with providers to look at where they're at 6 months in with service models to get a better picture of where we think we might end up at the end of the fiscal year.
Are there any additional questions? Mr. Rubin? Mr. Rubin, could you speak into the microphone?
Yeah, thank you. Comparing the $24,961,000 in March under capital assets, month prior, $27,282. So, what's between those two numbers, the sale of the building?
Really the asset that was the building. So it was the book value of the building that was sitting on our books prior to us selling it. So what you will also see as we go on into revenue and expenses is that you'll see us writing off the non-depreciated amounts from the building.
That's where I was going with that question. Good, thanks.
Move on. Okay. Moving on to revenue. Bear with me, all my papers are a bit jumbled here. So moving on to revenue, as you remember, we recently did budget amendment number 2, I believe. So the budget numbers that are in this are a more accurate reflection of what we are currently receiving. As you know, prior to budget amendment 2, what we showed as revenue had a bit of a variance compared to what we were actually receiving. So if you look at Medicaid revenue for the current month, you'll see that it's almost exactly on budget, just about $73,000 off, which is minimal compared to the total budget amount. And what you also can see is Healthy Michigan revenue is up above even what we budgeted as of amendment number 2. So that kind of further talks to you about people going on to Healthy Michigan and the fact that we are still seeing that DAB issue where people that were previously considered disabled, aged, and blind and falling in the regular Medicaid category, moving over to Healthy Michigan. So that does still demonstrate that, and we are currently still seeing that. The good thing about that particular fund source is we can commingle them now. The rate is much different, but we can commingle them, so if we have excess revenue in Healthy Michigan, we can use it to cover Medicaid. Moving down to general fund, that's exactly on budget as of this month. And then the only one I really want to point out in particular is that SUD other. You see that one, and that one is the one we talk about pretty regularly, is that it comes in chunks. It doesn't come once a month like some of our other fund sources. It comes in 2 to 3 payments a year. So it's primarily PA2 money. So you'll notice that that one will come and kind of not ever look really on budget because we don't necessarily budget the months it's supposed to come in. We don't always actually know when it comes in because it goes to the county first and then they give us our share of it. Does anybody have any questions on revenue before I move on to expenses?
So far, I don't see.
Moving on to expenses, there's, if you look at administration, year to date, we're almost exactly on budget, but what you see going on in the current month of March is a couple of things. We had a payout of a contract that we paid out in March, and in addition to that, that is where you'll see the removal of the non-depreciated asset for the building. So that's what you see going on there. That's a non-cash expense. So that's the clearing out of all of the building stuff that was left over from the renovation and things like that that has now been cleared out as of March in the sale of the building. Moving down to provider expenses, you'll see that core providers adults is under budget this month, but what's going on here between that and the core provider kids, you see how that one's quite a bit over. So you remember me talking about the fact that those ones were not breaking up correctly in previous months. So this is the catch-up month where all of the previous months are now catching up. So you see that big jump right here. After this, we should be fairly close to budget on those 2 particular line items because they're now being split correctly, but this was the year-to-date catch-up. So you see that one is almost $2 million under budget, whereas core provider kids is about $2 million over budget. So going forward, that one should look more on line with budget. Moving down to vocational, you see that that one is a bit over budget this month. So I believe that's the tail end of the direct care wages money being pushed out. So we're watching that one pretty closely just because that's the new service models we're doing. So we're watching those expenses pretty closely because we have switched to all of the service models as opposed to the fee-for-service model that was used historically. Beyond that, there's not anything that's too significant other than you see healthcare integration, which is OCHN. That one has no expense for the month, and that's because we pay them quarterly. So they get a payment once a quarter, so once a quarter you'll see that one be over budget versus the other 2 months of that quarter will be under budget just because we pay them up front quarterly from a cash flow, for our cash flow. Any questions beyond that?
What was depreciation that you credited for that building transaction?
I can get you that detail. I don't have it in front of me. I thought we were going to include that whole detail of journal entry in the board member packets, just because I figured you would have questions on that. If that didn't get to you, I can make sure it does. Yep.
Are there any other questions? You have more? Then we'll move on to the contract amendments.
So at the committee of the whole, we reviewed the items that are being changed in both the PIHP and the CMHSP contracts. The one we're looking at currently is the PIHP contract, and we scanned over the items that are being changed, and then you were provided with the 200 and some odd pages of in your packet, but I hope you just scanned it and looked at the changes because it's a lot of reading. But that one does need a motion for approval, and we'll go back to the department signed once you all approve that.
So you'd like to take up the First Amendment? Okay, is there a motion to approve?
Moved.
Is there a second? Second. It's been moved by Ms. Schulman, seconded by Ms. Respecki. Any discussion or questions? All those, let's have a roll call vote.
Mrs. Summers?
Yes.
Dr. Hahn?
Yes.
Mrs. Rathbeck?
Yes.
Dr. Todd?
Yes.
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 The motion carries. And you have a second amendment.
So the Second Amendment is for the CMHSP contract, so any applicable changes that they made to the PIHP contract, and then any other additional changes, again, that we reviewed, not last week, the week before, were included in this amendment, and it also need a motion for approval.
Is there a motion to approve?
So moved. Second.
It's been moved, I believe, by Mrs. Summers and seconded by Ms. Schulman. Is there any discussion? May we have a roll call vote?
Mrs. Summers?
Yes.
Dr.
Yes. Yes.
Yes.
Dr. Todd?
Yes.
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 The motion carries. Does that conclude your business?
It does.
Well, once again, thank you for that presentation from our Committee of the Whole. That was outstanding. We look forward to future ones. Okay. Next is the Children's Mobile Crisis, Matt Owens, Kathy Yunker, and Megan, is it Zaloni? Okay. Welcome.
Good evening, everyone. The board had requested some more detailed information about the Intensive Crisis Stabilization Services, which is the actual Medicaid title for the Mobile Crisis Services for Children. Megan is here this evening. The one thing that the department did fund is to have someone to be a point person to help coordinate and take on the duties that will be necessary to launch this service here in Oakland County. So while it is an unfunded mandate in terms of the services being provided, they did allow through children's block grant funding for us to apply for a coordinator position. So Megan is here with us tonight. She just started in this role a couple weeks ago, but she's hitting the road running. So I will turn it over to her.
And thank you, Kathy, and I'm really excited to be in front of the board this evening to share about Intensive Crisis Stabilization Services. Many times I'll use the acronym ICSS just because it tends to be a mouthful. So in regards of what is Intensive Crisis Stabilization Services for Oakland County, as Kathy mentioned, it is an unfunded state mandate. So it really requires all the CMHs to work together to provide this ICSS service for the individuals that they serve. So it will look very different in every community and operate very different. But in regards with Oakland County, it's our new mobile crisis service, and to really highlight that it will be mobile and community-based. And so ICSS will serve individuals 0 to 21, so this touches our young children, adolescents, and young adults. 0 to 21 that are diagnosed with a serious emotional disturbance or an intellectual developmental disability, including those with autism or a co-occurring disorder with SED and SUD. And so what ICSS really provides is short-term community-based crisis intervention services as well as a continued stabilization service. So it's really two parts, really the first part being to try to handle the crisis in the community with crisis intervention and de-escalation, then also provide psychiatric consultation if needed, and then additional service reports, service referrals, and then the second part being continued intensive stabilization. So whether that individual is already aligned with the provider, that would really be the responsibility for that continued stabilization working with the provider if already aligned. But if not, then making those appropriate referrals so that that individual and family is connected to the appropriate supports for additional crisis and safety planning. So what are the goals of ICSS? And this is pulled directly from the Medicaid Provider Manual, but ultimately, if possible, it's to try to handle that crisis in the community as long as that crisis is non-life-threatening. Also to reduce the severity of symptoms and to stabilize emotional and behavioral functioning, as well as try to reduce or prevent the need for care in a more restrictive setting, as well as providing those appropriate clinical assessments and care coordination, as well as connecting families to those community-based supports. So what will that look like for Oakland County, who will be providing that ICSS service? That is going to New Oakland Family Services. If you're not familiar with New Oakland, they are a mental health provider. They are credentialed and qualified to work with these populations, so SED, IDD, as well as SUD. And ICSS will be available for families and caregivers as a non-funded state mandate. We really had to look at how can this be accessible and efficient for families. So we're really having it available during the weekday hours, but in the evenings, and then with more proposed hours in the weekend, so more availability for weekend hours. And then, as I stated, they're a mobile team of qualified staff, but then if that call is made, that the mobile team would go out into the community, whether it's to the home or wherever it is in the community, they have a 1 hour duration response time that they have to meet. And how that was decided upon was Oakland County from the state is designated as an urban county. Now we're very vast. We have some rural outlying areas. And so how that is distinguished is rural areas have 2 hour timeframes to be able to meet that. So there was some discussion saying, well, can we be an urban setting but have some of the rural outlying areas to be able to extend that duration? However, they did say that we do have to meet that 1 hour requirement and that we are a 1 hour designated urban area. However, New Oakland has a track record of meeting this 1 hour time frame. They provide the same ICSS service to the same population in Wayne County, and they're committed and have a proven track record of meeting this 1 hour required response time. So what would it look like? When could ICSS and this mobile team deploy out into the community? And this is pulled again from the Medicaid provider manual, but potentially if parents or caregivers, they feel that ultimately they've utilized all their coping skills and they're requesting assistance from this mobile team. Or potentially the youth or child has the potential to hurt themselves or potentially others. Or if that child or youth's overall functioning, so whether it's emotional or on the behavioral side, is visibly impaired. So if it's aggression or lack of control or impulses or dangerous decision making, they can potentially go out. Also, if it's really needed, like immediate crisis intervention is needed to try to facilitate that youth or child staying in the home, to deter an out-of-home placement, and also to ultimately try to prevent an inpatient hospitalization or other out-of-home placement. And then looking at, so who is comprised in this ICSS team? So in regards of who would be deployed, there's a minimum of 2 individuals who are trained and qualified, one of which has to be a master's trained clinician. And then with the other one, it could be an appropriate professional under appropriate supervision. So they would be providing the crisis intervention, the de-escalation techniques, the appropriate clinical and safety assessments, and they'd be planning for what really would be next for, as far as care coordination or whether the individual absolutely needs a higher level of care. And with that team, they also have the ability to contact child-certified psychiatrists, so they have teleconferencing available during the full period of ICSS service times. And it's always, the teams are always supervised by a master's level clinician. And they always have master's level therapists that are going to be going out, whether that's a child mental health professional or a qualified intellectual developmental disabilities professional, as well as behavioral technicians. Then discuss a little bit about what happens during and after these crisis interventions. New Oakland has developed policies because if this individual that they're going out on, if they're aligned with the provider, they want to make sure that that provider knows and is aware that there is a crisis contact. So they have, in regards of automated responses, they have emails that are HIPAA compliant, that are sent out, but also in regards of contacting that case manager, that therapist, that supports coordinator by phone, if all at possible. Because they want to be able to have that core coordination discussion between the ICSS provider and the core provider, and then in regards of continued crisis stabilization and planning. And so for that care coordination, that will go with individual and family counseling and psychoeducation, but just depends if that individual is already aligned. If not, how can they align them and get them connected to the appropriate support? If not, they're the intermediary care until that alignment is able to be achieved, in which case they're referring to appropriate mental health, developmental disability, substance recovery services, as well as appropriate social service supports. In regards of our ICSS programming, we'll be finalizing all of our programming, the planning, the development, and the contract with New Oakland during the summer. And so we're working with in regards of trying to plan as far as how we're informing families and stakeholders, the appropriate communication materials we need, and as far as the press releases and flyers as we ramp up and get ready for the deployment. So when will this be available for individuals and families? We're looking at early fall of this year. That has to be ready by the new fiscal year. And we're also working with our community partners and our core providers as well, because they do have a role in responding to crises and planning for them as well. So in regards of our provider care coordination, we're working on developing ICSS policies and protocols because we want to be clear and define the core provider's responsibilities in regards of crisis planning, prevention, and responding, because those core, they ultimately have a responsibility not only for the care coordination, but really responding to these crises when appropriate. And so that whether the case manager, the therapist, the supports coordinator has to be ready to attend to these when it is appropriate. And then I have been attending provider management meetings just to make sure that leadership is on board, they're notifying appropriate staff, and as we continue to develop these policies and protocols, they will be shared with the provider network. In our development and understanding really the crisis needs in Oakland County, we reached out to our provider network because we really wanted to try to see what type of volume that this would potentially be or what the need would be, because this is a completely new service. So we reached out, and we asked for the core providers to relay onto us what are their crisis protocols for after hours and how many contacts really resulted in a face-to-face contact between the core provider and a youth and family. And from that, we did find out that absolutely the core providers do have after-hour crisis protocols. They have contacts in regards of who needs to be reached and the chain that they reach. But then going on from this, however, few crisis contacts during this after-hour period with this population resulted in actual face-to-face contacts. And then when it reaches that high level or risk of acuity, most commonly they are referred, the youth and families are referred to Common Ground or an ER for that initial triage and evaluation. And so really what this provides is an added benefit to families, really to provide this crisis intervention that is centered in going out into the community. So it's especially an added benefit to these families. Then in regards of budget development, I wanted to pass this along to Kathy and Matt for further discussion.
I had provided some discussion points on this one before, and just to recap a little bit, as Megan had indicated, this is an unfunded mandate. To emphasize that a little bit, to recap something I had shared before, the state had the intention that some of the regions, if not all, would have cost savings associated with hospitalization diversion from this program. In other words, by implementing this program, that it would result in less kids being hospitalized, and then savings from those hospitalization dollars would then be able to help pay for this program. In Oakland County, we have a pretty successful model of crisis diversion through the Common Ground programs, OASIS and OCHN, as well as the work done by the core providers that work with kids. And that results in only about a 12 to 14% admission rate for hospitalization for kids who present in crisis. As a result of all that, we probably won't realize a whole lot of savings and cost shifting in hospitalization as a result of this program. Probably some, but probably not enough to cover the cost of the services that, in order to have a service that's going to be meaningful and beneficial to the community. So at this point, we're going into this with that understanding. Some other regions have, we're told, worked and planned to basically put this program in place without putting it in place, so to speak, to check it off the box, to provide it only in a couple hours a day, so to speak. We are trying to actually make it meaningful without having it, the budget be too high. We're looking at the costs right now. We have to review that with F&B and get some costs in place, but we have some loose projections that are coming together. Overall, I just think it's important to recognize that this is going to be a cost. But we do see that this is going to be a benefit to the community and to the children and families served. Over time, you've also heard us speak about some of the changes in the environment over at Oasis, our crisis center. There has been a steadily increasing amount of folks coming to Oasis. We're seeing more people coming to Oasis rather than going to the ED. In other words, the amount of people that would have went to the ED by data is appearing to show that they're going to, the emergency department, I should say, are now appearing to go to common ground a little more, which is a good thing and what we intended that facility to be there for. The other thing that we're seeing is people staying at Oasis longer and a little bit of higher acuity folks with behavior aggressions, things like that. So the children's unit that's there is having some challenges with that sustaining. So this will be an additional help and resource to crisis services for kids and families. It will help take a little bit of that load off of Oasis, and we think overall will help our system. So we're going into this with positive intentions. We think it'll turn out to be a good thing for the community. But I think that's mainly the areas I wanted to. Yeah. I think one thing too that I wanted to note is that this technically isn't a new program, it's a new model. Just so we're clear on that, Intensive Crisis Stabilization Services has been around for a while. It was actually a requirement of all PIHPs to provide crisis stabilization, intensive crisis stabilization services. It was just outlined in a different manner. It was utilized solely as a hospital diversion after the pre-screening occurred. So if somebody had a pre-screening and they met hospitalization criteria, they would then have the opportunity to be looked at for consideration of intensive crisis stabilization services as an adult or as a child. MDHHS reworked the Medicaid language for this model specific to children, that they don't have to meet the threshold of hospitalization criteria, although they can and be utilized as a diversion, but it also can be whatever the family sees as a crisis or the provider who's working with them. So it's a little bit different. For adults, the ICSP program is still out there. We're just not utilizing that in Oakland, but Macomb has that program and other regions do as well. But I didn't want you to think that ICSP ICSS is a new all-around program. It's just a new model that we're going to be providing that all CMHSPs have to provide around the state.
I just also wanted to comment about how much this will support and assist some of our other community collaboratives. We intend to, as we get our hands around this and understand further the actual deployment of this, we think there's great potential in terms of building in direct calls from law enforcement out into the community to help support their interaction with youth. We've also had some initial discussions with DHS in regard to children who are in the foster care system. So our ability to respond to families in the community and then touch those cross-system partners will definitely be enhanced with this type of mobile response capability.
Well, it certainly sounds like a very important addition to our services. I'd like you to clarify one thing. Who contacts whom? You're a mobile unit. Can a family call you? Will you advertise a phone number, or will it come from the provider?
Yeah, so New Oakland will have a direct number that families can reach out to, but in regards of we want to make sure the providers know, because ultimately it could be even from internal, if maybe Access is doing an access screening and they say, ultimately we think that ICSS should be called or the mobile team should be called. So absolutely, it's a number that there will be a direct number, but ultimately it's going to be a service that if it reaches that high acuity level, the providers can use it as well.
Additional questions?
Family and community members can access that, anyone really in the community. I think that's a differentiating factor here, is that this isn't a matter of people getting sent to ICSS from Oasis or Common Ground. It can be accessed from the community. So
That was really my question. Could the individual family member call and ask for help?
they can.
Okay. Mrs. Summers?
This model seems like it should be of huge benefit. I'm really excited about it. I'm sorry it's not funded, but at the same time, I can really see where it's going to do a lot of people a lot of good. My question is, just for clarity, I think I might have missed it. With the ICSS team, is it a cadre of professionals, or are they specific people who are on call in terms of the psychiatrists and the clinicians and so on?
These will be clinicians that are already employed with New Oakland, and so it could potentially be in regards of some on-call staff, but they will have a designated staff.
They will have
Yes.
designated staff. I was wondering about consistency. Maybe that would be valuable. Thank you. Also, piggyback on Betty, how will that number be known for families if they're not connecting currently with services or a provider? How will we make that known?
We will be developing, as far as press releases, some newsletters, community flyers, and being able to disperse those in the community just so that families are aware.
We used to have those cards that had all the numbers on the back. Is it possible when the next printing comes that might be added to it so that it could be easily distributed?
Yes, and we will talk to communications I know they have in regards of planning, but we want to make sure that that is accessible, and so that is a great idea.
Dr. Tom?
Yeah, just further follow-up. We sort of used to have like lots of different numbers people could call. Nobody knew what to do, so we went to our access hotline number. If somebody decides, I would rather, you feel free to have another number out there, but I would rather have somebody be able to call into the hotline number and have somebody answering recognize that that's where they should be referred to, warm transfer right then. Is that in the plans, or?
Yes, we will have a warm transfer process in regards, even if a call potentially comes through the Common Ground crisis line. So we will work out all those referral pathways.
This is for Specky.
I'm just curious, as you're looking for your plan and budgeting, what kind of hard data were you using as you start to develop this? I mean, in numbers, what are we looking at in Oakland County as the need? You say that you're using data from Crisis Center. Is it pulled and tabulated?
So given that this is a new service and it's not utilized in the same manner of how many people have walked into Common Ground's Crisis Center and then been diverted, it's hard to tabulate it. So historically, people in crisis, they would end up in the emergency department, or they'd go to Common Ground, or that crisis may be averted at the core provider level. This is new in that people may call while they're in the home or the community or at school or something like that. It's hard to understand yet how or project how many people may access that. We can only go off the data that we have and go off of how much this has been utilized in Wayne County as a reference. So New Oakland has been providing this service in Wayne County. They have numbers that they've gone off of, so we can match theirs to our census and population data as well. But we also looked at data from Common Ground in terms of how many crisis calls they get of similar nature, how many times the core providers have come into need of addressing a crisis in the community, gotten calls from people. That was as best of an estimate we could get.
Mr. Landsman?
Yes, thank you for your presentation. Megan. So you said that Detroit Wayne's already been operating a program, and I know that a lot of our providers already have programs in place during the day, and a lot of them deal with after-hours on-calls. In fact, I can remember even Annette mentioning that she deals with after-hours calls. So I wondered, why use a third party to support this when the families and the children are already used to they're already used to a person, and those folks in our providers already know who they are. So why not have those folks get compensated for doing the after hours on call for de-escalation? Just
The core providers, by contract and understanding of their service practice, are supposed to address crisis. And due to a degree, this is a kind of a area of line of where they meet, and this becomes an intensive crisis intervention. So this would be at a point where the potential for this kid being in a crisis that could lead to an emergency department, to hospitalization, to removal for law enforcement coming, things like this, that tends to be a little more out of scope. I think we could get into the discussion of whether or not we build out the core providers to do that level of crisis intervention, maybe what you're suggesting, but we didn't go that path. And probably a good time for me to speak a little bit about what we did here to build this out. The state had rolled this out with the expectations that this be in place by the end of this fiscal year. We had an application process that we had to fill out and go through with the state and get approved. We didn't get that approved until March, sometime in March, and we were, I think, the third in the state to get approval. Several others had not yet received that approval. So after that, we've been moving forward. The overall, the plan to go with New Oakland, while they have a track record with this, they were certified, they have some dock time for children and so forth. Those things made sense to try to do this within the time frame that we had. This is technically being looked at sort of as a pilot with New Oakland to move this forward and get it in place. We do intend on doing a request for proposal next year for this service and rolling this out to provide fair opportunity for other potential providers of this service. But New Oakland will be doing this for the next year as we roll it out. At that point, we can look at different models, different ways to do this. We're pretty comfortable with the model we have right now and getting this off the ground. The state is approving of it as well.
I
think you're saying that fine line between where the core provider steps out and they step in, and certainly we want them involved in that process.
Sometimes they're a little bit closer to the folks. They know who the children are, so there's a continuity of care factor. And then, but I could also see the other side of it is sometimes they're too close. So having an independent third party handle the de-escalation sometimes works better too. I mean, it's 6 of one, half dozen of the other. But I was curious about that perspective.
Hope here is that they have them actively involved in the process, minimally, at this point.
Ms. Bunchu.
And you guys may want to speak to this. My understanding is that not every call in person who will come through this is going to be associated with a core provider. So I believe that that's something that really, if you depended on it just to be through the core providers, they would be serving people who are not already in our system. So I'll let you guys expand on that.
One of the teams we've been meeting with in planning is our access team. Because down the road, what we'd like to look at is the ability for this team, since they're out there in the community, to gather the information that our access screeners would need to do an eligibility screening. What we want to do is make sure that families don't have to go through duplicative processes. So if the ability of the crisis team to go out, meet the crisis need, address the linkages to other resources, gather information, get it to the access team, and that family then the next day can have a determination about where to best receive those resources. So yes, it is intended because, again, it is a crisis service. So it is part of our safety net, not just part of our regularly provided children's services. We can and will go out to families who are not currently served.
One last, going back to advertising, do you ever make use of public service announcements? Or, for example, if Wayne County has this, could you join forces to have the television networks, give the number for Wayne County, the number for Oakland County? Do you do that at all?
We're working with Christine Burke on developing a communications plan specific to launching this service. We want to be cautiously enthusiastic about our rollout because, again, being unfunded, we need to understand what the demand is going to be in Oakland County. I do believe, though, that the department does plan to look at implementation. At least that's what we're overhearing as we're listening to the children's administrators meeting across the state. And if funding is needed down the road, that may be there. That would allow us then to expand hours, really launch a greater penetration into the public awareness.
Additional questions? Mr. Landsman.
So I misunderstood because the slide I was looking at said it was that you serve individuals 0 to 21 who have SED, DD, autism, or co-occurring with those. So you're saying it's open to any 21 or under citizen, if you will, of Oakland County?
Yes, and that's what I pulled from the Medicaid provider manual, but essentially, yes, I mean, New Oakland has to be prepared in regards of whether it's somebody with an other, like a private insurance or possibly uninsured. So yes, they do have that capacity, but in regards of us following individuals within the private side insurance, we wouldn't be following those. But especially in regards of if they're uninsured, we want to see if we can get alignment and then a Medicaid application going on to be able to assist that youth and family.
Are there additional comments or questions?
I just want to mention it is the department's expectation that the CMHs respond to families in crisis, regardless of their insurance status or their eligibility status at the time of crisis. So it is different language than what appears actually in the Medicaid manual, absolutely. So again, we'll be needing to look at how we balance that because those will not be Medicaid encounters then at that point.
Well, again, it sounds like a very important service for our community, so thank you for the presentation. And next we'll have Jillian Trumbull. Good evening, Jillian.
I'm afraid my presentation won't be quite as interesting as Megan's and Kathy and Matt, but I did want to give a service network update. Moving on to the first slide, and this is my standard slide that gives you an idea of how many contracts my team oversees currently. So we have contracts with 3 adult MI providers, 2 providers for children with serious emotional disturbances, 2 IDD or intellectual and developmental disability providers. We currently have contracts with 13 employment or skill building providers, 11 ABA or applied behavioral analysis providers, and then as you know, we're preparing for specialized residential and community living support services contracts effective fiscal year 2019, which is 10/1 of 18. So that will add to our network an additional approximately 130 to 150 contracts. We plan to hold contracts with these providers effective fiscal year 2019. We are on target for our 10/1/2018 implementation date of contracts. The team issued a request for qualification in March of 2018, which was due in April. The team is currently working to review all of the credentialing or qualifying packets that came in. They're reaching out to providers as needed to get additional information and approve those providers into the network. Our intention is to maintain the current network of providers. As I always say, I would be remiss if I didn't say there are some caveats to that. If we find anything in the process where a provider is a Medicaid sanctioned provider, or if they're not going to be able to come into compliance with HCBS, that would impact our ability to be able to contract with them To date, as far as I know, that has not happened. We certainly have providers where we're working toward HCBS compliance, but we haven't come across any Medicaid sanctioned provider issues or anything of that nature. So the intention is, I'm not sure what happened there, but I can talk about the slide. What the slide says is there were 2 provider informational meetings that were completed and 2 meetings that were focused on individuals and families served in terms of informational meetings. At this point, we are on target to hopefully have all of the applications reviewed by July, which gives us about a quarter to get contracts in place for the 10-1 implementation, which puts us in pretty good shape. The other piece of information on this slide is an important piece of information, and that's where you can find all relevant information related to the RFQ on our website. So on our website, we have the frequently asked questions and any other relevant information related to this RFQ. Our website is www.oaklandchn.org. And if you look at the top left, there's a tab that says RFQ. If you click on that tab, you will find every bit of information related to it. So before I move on to home and community-based settings, are there any questions?
Mr. Furman.
Julian, actually, Jonathan, could you move that? I asked last month Julian generally about how communication has gone with foster families and just wanted to make sure that that continues apace.
Yeah, that's actually a good point. And I had a note and didn't mention it here. We have, or we're working on, I should say, scheduling a meeting specifically with foster families. We do recognize that we may need to look at our contract document itself and some of the requirements associated with that for foster families. That was a recommendation that came from MORC and that we really are taking to heart. So we have a meeting scheduled with them to meet with them and answer any of their questions specifically, look at any of the contract requirements. And then I know Jen Hillier, who is our contract and procurement specialist, has actually sat down independently with foster families as needed to work through the application with them on a one-on-one basis.
Super, thank you.
Sure. Any other questions? Okay. I did want to spend a little bit of time tonight on the home and community-based setting rule. I know the board is used to me having at least one slide related to it on my monthly updates, but we are moving forward, and I thought now would be a good time to give a little bit more detail on where we're at in terms of the HCBS rule, the home and community-based setting rule. So we are continuing down the corrective action plan process. This is for phase 1 of the habilitation supports waiver surveys. So if you remember, the surveys were done in 3 waves essentially. There was phase 1, which was about half of our 862 HAB supports waiver enrollees. Then there was phase 2, which was the other half of those HAB supports waiver enrollees. And then the B waiver surveys, and that was all the thousands of other people who are either receiving CLS, community living support services, in a licensed setting or other types of vocational or facility-based services. So the B waiver survey process is continuing. We're in the phase 1 part of the corrective action plan process for the habilitation supports waiver. So I know that's a lot to digest and can be quite confusing. But right now, we are working through that process, and about 70% of the corrective action plans for that phase 1 have been approved. So what the process is the OCHN team reviews every corrective action plan, and then they either approve it or send it back. And then once it's approved, the provider has 90 days to implement the corrective action plan, or to use the federal and state terminology, the remediation, and then our team goes out and takes a look at the corrective action plan. So 70% of the plans have been approved. That does not mean that 70% of the sites have gone out and been visited at this point. That there's 90 days from the time of approval for them to remediate, and then they'll go out and do the visit. But the team is moving right along with that. Once the corrective action plan and the remediation process has been completed, then that provider is deemed to be in compliance with HCBS, and OCHN has an obligation to complete a site review at least annually to assure that ongoing compliance. So are there any questions on that right now?
Well, again, this is unfunded, right?
Yes.
Mandate.
Yes.
So which team do you assign to this? I mean, with everything else there?
Yeah, well, for a while, it was sitting with the service network analyst on my team who oversees the ABA contracts. It became an overwhelming amount of work for her because she also has 11 ABA provider contracts. So the position, because of the ongoing site visits, now sits on the quality management team under Marquita, and then there's coordination, though, with the service network team and others within the organization. So that corrective action plan process approval is not just one person. That's a team within OCHN who's looking at them and making decisions about approval.
Sure. Yes, Mrs. Summers.
Quick one. How many corrective action plans were there? How many were submitted?
That's a great question, and I don't know the answer. It was hundreds. I can get the specific answer for you, but if you remember, the corrective action plans are by individual, not provider. So if a provider is serving 10 people, they could have 10 corrective action plans. There were very few providers, both residential and non-residential, that were just in compliance with no corrective action plan, and most of them had more than one cap associated with it. So it was hundreds.
Handle on
Sure.
what 70% meant.
Yeah. And this is just that first part. So the first half was about, I want to say like 360-ish people were surveyed in the first part. So we're talking about a maximum of 360 corrective action plans for that first section.
Okay, thank you.
Sure.
Additional questions? Okay.
Okay. So moving on, heightened scrutiny is something that we've talked about quite a bit. Shadia, you can go ahead and go to the next slide, sorry. So the heightened scrutiny process is one for providers or individuals whose services are deemed not able to come into compliance with the rule, so either isolative or institutional in nature. The heightened scrutiny process is being facilitated entirely by the Michigan Department of Health and Human Services. So while at the PIHP level, we're overseeing the CAP process and the remedial action, the heightened scrutiny process is being overseen by MDHHS. So the heightened scrutiny letters have gone out, again, just for this first phase we're talking about, to individuals whose services were deemed either isolative or institutional in nature, and the providers have received those letters as well. The first step is really a question to the individual: do you want to continue receiving services in this setting, in this location? If the answer is no, you begin transitioning to other types of services that are in compliance with the rule. If the answer is yes, the next step is the provider: do you want to continue to provide these services? If the answer is no, again, that transition process. If the answer is yes, then it goes to the Heightened Scrutiny Review Committee. That Heightened Scrutiny Review Committee is going to do a site visit, paper review. I imagine there will be other steps in that process as well, and is inclusive of not only MDHHS representatives, but advocates, people served, and fortunately OCHN did get a seat at the table, so we do have OCHN staff who will be sitting on that Heightened Scrutiny Review Committee as well. It's a pretty big time commitment once a week for at least a year to go through that process. So as those meetings start, I think we'll have more information about what's going to be able to come into compliance and what's not. But I wanted to let you know that those meetings will be moving forward soon. And then the other thing that's happened recently is advocacy groups have reached out to the department to ask for some guidance on deadline consistency. One of the other things you may remember is the initial deadline for compliance with the rule was March of 2019, and CMS extended that to March of 2022. Some of the state documents still reference the original 2019 deadline. Others reference the 2022 deadline. So we are looking for some consistency as to whether it's a March 2019 across the board, if it's a March 2022 across the board, or if there's some delineation. So there's a question out there related to that. The other thing I wanted to talk about related to HCBS is new providers. So effective fiscal year 2018, so that was 10/1 of 2017, any new provider coming into the network has to already be in compliance with the rule. So if we have new contractors that are reaching out to us as the PIHP and CMHSP, or are working to get contracts with core provider agencies, those providers have to be assessed and deemed in compliance with the rule, which would be the completion of the survey process and credentialing to assure that they're meeting the intent and the spirit of the rule. So there have been some providers that have come new to Oakland County since that time, and either the core provider or OCHN, depending on where the contract sits, has been working through that process. Are there any questions related to those 3 slides? Okay.
Let's see.
Okay, and then just finally, we are continuing provider meetings to provide ongoing guidance. We have switched those meetings to once every other month, and that was really based on the provider feedback. I think we had originally started with twice a month, and then as we started moving down the process, they really only needed once a month, and so now we're on an every other month basis. That said, the HCBS analyst, she sits not too far from me. I hear her on the phone with providers pretty much all day, every day, answering questions related to the process. So Oakland is very committed to working with providers to come into compliance with the rule. And then I did want to just point out again where that information can be located on our website. Every bit of information related to HCBS that's been promulgated by OCHN or by the state or the federal government related, not about every single state, but either related to Michigan or as a whole, is on our website. So again, that's www.oaklandchn.org. There's an Access and Services tab near the top right, and if you go to that drop-down, there is a drop-down for HCBS rules, and everything is in that section.
Are there any final comments or questions for Jillian? Well, thank you very much, Jillian. Okay. Next, we have Christine Burke, and May is Mental Health Month. Good evening.
Hey, everyone.
Good evening.
How are you? As we have in the past, I will be asking the board to recognize a proclamation acknowledging May as Mental Health Awareness Month. I did want to inform you about some other activities we participated in throughout the month. Some of you know we held our Law Enforcement Appreciation Breakfast. We coincided it with May 10th, which is also designated as National Children's Mental Health Awareness Day. We had green ribbons that we pass out to our staff. We always try to engage the people who work here in keeping them aware of activities and observances, and it tied in well when the law enforcement came. We were able to give them green ribbons also. We participated in the Walk a Mile rally, which if you have not been there, you would be overwhelmed by the volunteer presence of Oakland County. Almost 75% of the volunteers who help make that event successful are from our county. They lead the walk around the Capitol. They are in charge always of the flags. We take care of all the statements for all of the counties throughout the state. We also coordinate shirt colors, and we lead the announcements, and we help with the statements that each county reads. So I'm always very proud and pleased of the people who work here and their involvement, and then the staff who come to cheer us on as we're running around working. That's fun too. So, in regard to the proclamation, we did send it to all of our communities. We have heard back from 12 cities so far. We will get proclamations well into mid-June. Sometimes they ask us to attend their city council meetings, and then volunteers go. They read the proclamation, and sometimes they just send them to us in the mail. We do keep track of that information. We thank them for their support, and then in the following year, we also send them in the letter just letting them know that we appreciate their past support and we're asking for it again. And with that, I'm going to read the proclamation. Whereas mental health is important for our individual well-being and vitality, as well as that of our families, communities, and businesses. And whereas 1 in 5 Americans experience a mental health illness that requires treatment at some point in their lives. And whereas 1 in 10 children has a serious emotional disturbance that, if untreated, can lead to school failure, physical illness, substance use, jail, and even suicide. And whereas May 10th has been designated the National Children's Mental Health Awareness Day. And where stigma and stereotypes associated with mental illness often keep people from seeking treatment that could improve their quality of life. And whereas mental illness is a biologically based brain disorder that cannot be overcome through willpower and is not related to a defect in a person's character or intelligence. And whereas mental health recovery is a journey of healing and transformation, enabling people with a mental illness to live in a community of his or her choice while striving to achieve his or her full potential. And whereas mental health recovery not only benefits individuals with mental health disorders by focusing on their abilities to live, work, learn, and fully participate and contribute to our society, but also enriches the culture of our community life. And whereas the Oakland Community Health Network and its service provider agencies are committed to inspiring hope, empowering people, and strengthening communities. Now, therefore, be it resolved that Oakland Community Health Network hereby recognizes May 2018 as Mental Health Month. OCHN calls upon our citizens, government agencies, public and private institutions, businesses, and schools to recommit our state to increasing awareness and understanding of mental illness and the need for appropriate and accessible services for all people with mental illnesses to promote recovery.
Thank you, Christine. May I have a motion to approve the proclamation?
So move.
Is there a second?
Second.
It's been moved by Dr. Taub, seconded by Dr. Klotz. Any discussion? All in favor?
Aye.
Opposed? The motion carries. Thank you, Christine.
Thank you.
And now we have a series of reports. We will begin with the RRAC report. Jonathan Landsman.
Good evening, everyone. The Recipient Rights Advisory Committee met on May 3rd at 5:30. Since we had a void in our vice chair with Paul leaving, the board vote or the committee voted and elected Amit Agrawal as our vice chair. He then facilitated the meeting. Vicki Suter, who's the Director of Rights and Advocacy, presented on the review of the annual report for the recipient rights. She presented a PowerPoint deck on this year's annual report and facilitated discussion with our RRAC about the annual report that had been posted with the state's DHHS, similar to the same deck that we as a board saw last month. We also reviewed the Recipient Rights 4.1 policy. The policy addresses complaints and the appeals process. It needed to be updated because of some minor changes in the state's CMH contract with us, along with some name changes that we've obviously gone through. Welcome to OCHN. And then last we reviewed the site review survey. Through the end of April, or 7 months, we've now, for the fiscal year, we've seen 224 of the 375 sites. That's approximately 60% have had their annual visit. So we are on track. We're on track to visit all of the sites. Lastly, Paulette Howell was not. Excuse me. Paulette Howell was not in attendance. However, there were 3 appeals that are currently in review, so I did not get the details about those. Our next meeting of the Recipient Rights Advisory Committee will be held June 7th, Thursday at 5:30 p.m. Thank you.
Thank you. Are there any questions for Mr. Landsman? Next, we have the Consumer Advisory Committee, Lois Schulman.
I'm reporting on 2 meetings. The first was April 18th. Ursula Bolton, Vice Chair of the CAC, was acting as interim chair since Anita Warner submitted her resignation due to her not representing My Place Drop-In Center at this time. Ursula was elected by the membership of the CAC as chair at the meeting. Deanna Martelli presented the draft of the Oakland Community Health Network Utilization Management Manual to the CAC. The manual section deals with residential moves. The manual only talks about movement and will not change the least restrictive environment. Carlton Aikens updated the CAC on future events which have now passed. The one, Your Voice, Your Value, was actually really wonderfully attended. The reason it was not held here at our building was we had about 250 to 300 people. Then I would like to report on the May 16th meeting. I did not attend that. Malkia Newman attended for me, and I'll read her report. There was extensive public comment about public transportation, with many people expressing their views pro and con. There were also some discussion about 298 and the need for people with lived experience crafting their own advocacy messages and being more involved in efforts to privatize the public system and make work a requirement for eligibility for Medicaid. Malkia Newman brought information of all of Oakland County's elected officials at federal, state, and county level with their contact information included. Mike Daly will then pass this out to the committee. The elections were held for vice chair. Glenda Vidish was elected vice chair. Matt Owens came to discuss the RFQ process with the committee. He first informed the committee that Christine Burke is reviving advocacy efforts and encouraged the CAC members to get involved at whatever areas they're most interested in to let their voices be heard on these very important issues. He then went on to discuss the process of the RFQ, which has taken place so far, and what the steps are going to be. He assured the group that it's not OCHN's desire to limit choice or close down any providers who are currently operating in Oakland County. Everyone who has not responded to the RFQ is being contacted and technical support being given. Committee reports were given, no public comment, and that was respectfully submitted by Malkia Newman for me.
Excuse me. Thank you, Ms. Schulman. Any questions? Next, we have Dr. Klotz with the Oversight Policy Board Committee.
Okay. Dr. Klotz owes everybody an apology. So that I wouldn't forget my report, I put it in my substance use disorder folder, and I forgot the whole folder. So little Freudian slip there, perhaps. I just highlight some of the things I had in the report, but what I'm going to do is email or text it, fax it to Victoria, and anybody who'd like a copy of it can get it through her or through me. But some of the things that were highlighted in it was, again, this is a repeat, but Chuck McDonald, joining us with the veterans, and he brings with him years of experience working with veterans and substance use and services for veterans. It's no surprise to anybody that the opiate problem continues to be a crisis in this country. Michigan is struggling like everybody else, and the numbers continue to go up. Public Act 2 surveys will be coming up soon, and as I recall, those jewel pipes, or the pipes that have gotten rather popular, as I recall, will be included in the survey, and surprisingly, California is leading the way to that. They're putting, they've got a negative attitude about what it's doing to our youth and how it's being adulterated. People are taking the vials out of those mechanisms and adding their own substance to it. So obviously, it's problematic. Our own 52nd-1 District Court has been certified for their work in substance use and alcohol, and it's been certified by the Office of Court Office Administration and also Supreme Court, and they're the only one in the entire state right now that's certified. So once again, Oakland County is leading the way in the various things that we do. And then I have an item on the sobriety court. So next meeting, I promise to have a more fulfilling report. Thank you.
Thank you, Dr. Klotz. Are there any questions for Ms. Schulman?
What is the sobriety court?
Just what it says. It's people can go to it who are in the throes of alcohol problems and issues, and it's a relatively new program, and they can go right into it, as I understand, without any appointment or whatever, and get immediate help for their alcohol problem.
That they have.
I think it's basically through Common Ground, you know. But all the courts are aware of it, and it's been well received by the judges, and so it proves to be, even though we're at the early onset of it, it's proven to be successful. The word is getting out.
Right.
Yeah.
Thank you, Dr. Klotz. Next, we have our director's report by our interim director, Diana Bunchu.
Thank you. Good evening, everyone. So yesterday, Annette had coordinated a meeting and had Alan Bolter from the Community Mental Health Association of Michigan come in and provide a legislative update. One of the things that Alan talked about was how Section 2E was added to Boilerplate 298. And what this language does is it would allow the Medicaid health plans to be able to bypass the CMHSPs at the pilot sites. So that was one of the things, was when there was talk at 298, Lieutenant Governor Calley had a work group, and there was really this feedback and everybody saying we did not want a privatized system. So the language that has been added, what really the concerns are, is that what this does is it could pave the way for complete privatization very quickly. So when we look at what's been happening across the country, we have other states that have done privatization of mental health services. Some of those are Illinois, Kansas, and Iowa. Both Kansas and Iowa have both been in the news quite a bit, but I want to talk about a couple examples from Iowa. So when this promise was made to privatize Medicaid as well as mental health services in the public mental health system, it was estimated that there would be a $232 million savings. This savings was revised earlier in the year to be $47 million. What I've been reading is that this number continues to change, and no one exactly knows why the number is changing. It's going up and down without much data behind it and explanation. There were 3 health plans that were selected in Iowa, and one of them has already terminated their contract. So, for example, I was reading today, and one of the health plans was talking about how they had been losing about 57%. So one of the things that we need to remember is that we are looking at privatization is that you do have shareholders, right? So this particular company was a publicly held company. So what that means is they have shareholder meetings every quarter, and they are talking about how are they going to decrease that 57% loss. So as we've been reading and seeing, what's happening is cuts in services, cuts to provider payments. There are providers that are talking about that they haven't been paid in over a year, and you've had a lot of providers actually going out of business. Additionally, I think it's also important to point out is that after they awarded the contracts, they all went back to Iowa and to the governor and stated that they were losing money and that they need an increased rate. So they got an increase of 3%, and after that 3% increase, you did have one of those, which was one that I mentioned that had exited the market. So for us, what we're really looking at is that while we know that there's always things that can be changed in our system to help it and to make it better, at the end of the day, we are all here to try making the system better and for the people that we serve. We are not motivated by money, by profits. We are not answering to shareholders outside of those people that we receive services and who are our personal stakeholders. So what's really important is that there seems to be a lull in advocacy. And one of the things that I also want to make sure that I'm talking about is for any of you that attended last night legislative update, Alan said that he thought that 298 may go away. But I think what's really important for us all to know is that the chances of it not being replaced by something are very, very slim. So instead of 298, it might be 304, it might be 250, it might be 1,000. But there will be this continued talk about integrated care and about how privatization could serve people better. So it's important that we come together from all of our organizations, from advocates to community mental health here in Oakland County and across the state, and how do we preserve the system and how do we best make it work for the people that we serve. It is always important for us that when we are looking at 298 and the happenings that we see is asking, what is the impact? Is it really meeting what 298 set out to do? So once again, we're continuing to hear about integrated healthcare. If you think about my report, I can't remember, I think it might have been last month, I had talked about integrated care and some of the things that we are doing with Oakland Integrated Health Network and the results that we're seeing from those partnerships and from other integrated health initiatives. So, it's important for us as we're watching this budget come together. Things are changing daily and weekly. We are most certainly staying on top of those, working with different advocates, different people at the legislature, and making sure that everybody is both advocating in a positive way and that we are making sure that we are reaching out to our legislators. There is one thing, and Alan also mentioned this yesterday, there is one thing that people watching as well as those who are in the room, that you have a voice that those of us sitting up at the table do not have. Our legislative consultants do not have, and nor does CMHA. You are a voter, you have dollars, you have a voice. So once again, if this is something that is important to you, we are most certainly encouraging you to reach out.
Hello? Oh, thank you, Ms. Bunch. Are there any questions for her? Okay. I'm going to ask you to pass that down. Under other business, I'd like to give a brief update. I had the pleasure of having lunch with Ms. Annette Downey, our future CEO, and we both enjoyed it and got to know each other better and discuss the future of OCHN. At our last Committee of the Whole meeting, at the end of the meeting, I updated the board that the Executive Committee had met with our lawyer and Edna White to review the draft CEO contract. We made some housekeeping changes. We agreed on a salary offer, and Edna was to make changes to the draft and send it to the lawyer and committee for final review, and then send it to Annette for review. And all of this was completed. Today, the Executive Committee met with Annette and finalized a proposed contract. At her request, she will meet with the board in closed session to discuss and finalize the proposed contract on June 19th. That's our board meeting date. So we hope to have Ms. Downey on board on or about July 9th. So we look forward to that, and we're trying to get that finalized. One other thing, I wanted to mention, I think everybody on the board really received the financial presentation at our Committee of the Whole meeting a couple of weeks ago. And I'd like to see all of our financial presentations, whether it's training or just a presentation, conducted at either the board meeting or Committee of the Whole to ensure that the public can benefit. If Anya conducts Finance 101, I think not only the board will benefit, but the public. And those are the two meetings which we have the largest or greatest public presence. So we hope to go forward with that. I've talked to Anya and Diana about that. And so that ends my presentation. And next opportunity for public comment. Would anyone like to make public comment at this time? I'm surprised. You're sure, Mr. Cummings? Well, anyway, we'll move on. And are there any board member comments? Mr. Landsman.
Well, I'm hoping that when we have these future financial discussions, that we have them during the regular board meeting, as I'm really finding it difficult to attend any of the committee of the whole sessions in their full duration. And I'm not able then to get I'm not able, unless I watch a replay of them, to hear the answers to the questions I put forth.
Actually, our meetings are live streamed.
Yeah, well, I'm working either to watch it live streamed. Otherwise, I would be here too.
Well, we'll do our best to accommodate you. I have to accommodate the full board, okay?
Of course you do.
Next, would anybody else like to make comments? Yes, Ms. Schulman.
I attended the meeting last night with Alan Bolter, and I wanted to compliment our staff that was here, Annette Downing and Diana. Kathleen Kovach, who did a fabulous job. And at the end of the meeting, the audience was asked if they would attend more of these sessions with the staff, and everybody raised their hand. So I'm hoping to see more of that on a regular basis, and I truly appreciate it, because the more I sit through hearing the same report, so to speak, every time I come away with something a little bit more helpful to me and my understanding of the whole system. So I really appreciate all the effort that was put into that, and the conversations back and forth. So thank you.
Thank you, Ms. Schulman. Are there other comments? Mr. Rubin.
I would like to have a presentation of our two investment bankers at one of our meetings, probably individually rather than both at the same time, and to explain to our board the investment policy and what their fees have done to the investments that we have made. And perhaps I can send you a list of the questions in advance.
That would be great, and I think that's already scheduled. I remember hearing Anya talk about that, so it should be coming up. Do you know what?
Could you tell me when they will be scheduled?
I believe one is scheduled for the next committee of the whole, and the other one might be scheduled for the following committee of the whole. So we have separated them. They're not coming at the same time.
I'd like to send you a list of the questions that could be very interesting for our board, and some explanations as to why there are some heavy losses that they're reporting.
And we know that you had given us very similar feedback during the financial meeting, and Patrick did take note of those as well.
Additional comments from board members? Well, in that case, did you have any final comments?
Well, this will actually be my last board meeting as the interim CEO, as I will be on vacation with my family at the next one. So I want to say thank you for everyone's support, from staff to our providers as well as the board. It has been a great experience and really an honor to have this privilege. So thank you once again.
Well, I think you've done an excellent job, and it's not easy to step into an interim position. So thank you very much. And with that, this meeting is adjourned.
Obviously not get any answers to any questions I asked, since everything will be done at a count meeting. And I can't get here before 5. The count meetings just happen to end by then. Just like all the financial meetings just happened in the last cows where we did deep dives.
Yeah, I remember you.
Yeah.
Yeah, you